I want to thank you very much for inviting me, and I hope that this is informative, and I hope we'll have some time for questions afterwards. So the topic, as you probably all know, is physician well-being, psychological PPE in the age of COVID and beyond. Oops, what is this? Okay, you know all this already, so I'm gonna skip to that. So the objectives for this talk are to describe a framework for understanding the role of individual and system-level factors related to burnout in physicians, to review reasonable evidence-based solutions to enhance individual resilience and to mitigate stress while practicing medicine, and to identify potential systemic solutions as well as action steps, tools, and resources to help further improve well-being, enhance growth, and promote resilience. I don't really have disclosures in the way of pharma, but I am paid by Montefiore Medical Center, and I have a small salary as a senior scholar from the ACGME. So this is just sort of a little overview about what I'm going to talk about. I'm going to talk about burnout in physicians and trainees, although I'm sure you all know about that. I'm going to talk some about depression and suicide, systemic challenges, how do we achieve well-being, whatever that means to you, and what will it take to get there. And, we want to get from suffering to flourishing, and we'll talk about languishing, coping, and performing too. Now, what I want to say is there's been a lot of talk about suicide, and, I know that's very distressing to all of us, but suicide is really just the tip of the iceberg. And what's underneath it are a whole lot of other issues in mental health: anxiety, insomnia, stress, feeling helpless, feeling overwhelmed, depressed. So, we really want to focus on what are the causes for the things that are going on for us, both individually and systemically. These issues are not new, just want to say that. Physician mental health, in that arena, the AMA convened a panel of experts 20 years ago, and they concluded that physician well-being, physician mental health was not well-resourced or studied or worked on, and they recommended changing everything, and of course, nothing happened then, but I think we're at a different inflection point, as Malcolm Gladwell likes to say, a tipping point. So hopefully we're going to make some progress here. Now, I think that this is really, you can probably all relate to this. This is what we're calling, oopsie, I'm trying to get this, I don't know where this thing can go. Anyway, the physician personality, believe it or not, it's why you got here a bit. The compulsive triad of being high-achieving, perfectionistic, and compulsive, and it leads to doubt, guilt, and an exaggerated sense of responsibility, among other things. So the thing is that some of these characteristics are really adaptive. They make us committed to our patients, they give us our diagnostic rigor, they help make us thorough, they help make us want to stay current with all the newest data to make people better, and we acknowledge the responsibility that we have for the trust that our patients put in us. But what's not so adaptive about this is, and this is the maladaptive piece, is that we have problems allocating time for family, setting limits, differentiating healthy self-interest from selfishness. We have trouble relaxing. We never think we're doing enough. We never think we know enough. And we have a tremendous sense of responsibility for what we can't control. And of course, you can imagine how COVID contributed to all of that, the pandemic. These components of burnout, I'm sure you've all seen till you're blue in the face, so I'm not going to review them. But I did want to mention that in a review of over 180 studies involving more than 100,000 physicians from 45 countries, there were more than 140 unique definitions of burnout, resulting in a prevalence rate ranging from 0 to 80%. So although we talk about burnout, and we talk about exhaustion and depersonalization and ineffectiveness, they mean different things to each one of us and to each of you in this room, I'm sure. I think it's always important to help understand how the brain mediates these factors. So this refers to areas of the prefrontal cortex, which are involved in keeping us alert And when it's weak, that leads to fatigue and stress. So examples of prefrontal cortical dysfunction include forgetting things, thinking concretely, having trouble concentrating, being disorganized, having impaired decision-making, having reduced, I'm getting some kind of impaired decision-making, reduced insight, judgment, and a moral conscience, decreased empathy and compassion, decreased optimism and persistence, decreased self-regulation, and inhibitory control. And as you can see, the clinical consequences of this are medical errors, problems handling complex tasks, suboptimal care, decreased commitment to professionalism, impaired communication, cynicism, and an increased likelihood of unprofessional behaviors. So physicians are vulnerable here. I mean, this is our job. We're vulnerable to burnout, which in turn makes us vulnerable to depression, which can also lead to second victim syndrome, which means we're responding to traumas on the job, and we're experiencing things as a second victim. And it can lead to suicide, and there are specific factors, which I'm going to talk about a little bit, that are implicated in the risk for suicide. Now, these organizational factors, many of you have probably heard about this and seen this, and these are really key and big in medicine these days, which I call the medical industrial complex. There's increased performance measurement, the focus on quality, on cost, on the patient experience. Doctors have loss of control over their work. There's inefficiencies in the practice environment. The EMR, which maybe someday, Siri and Alexa will take down all the information we need and just put it into the computer. But right now, everybody's very frustrated with the EMR. And there's the increased complexity of medical care. This is very different than when I was an intern too many years ago to count. Other drivers of burnout in medicine are the stress mediated by the long hours, fatigue, and work compression, which you all see, as well as the intensity and complexity of the work environment, the decreasing length of stay with the increasing acuity of our patients. When I was an intern, people would be admitted for 3 weeks, not 3 hours, and with a lot of the patients who were very complex illnesses, we didn't have the same armamentarium of treatments that we have now. There's been a loss of meaning and autonomy, disengaged leadership, and problems with work-life integration, as well as COVID. And the work-life integration piece relates to the fact that we're never sort of really away from work. We have these, our devices, our phones, whatever, they're with us all the time, and we never really get away. So in addition to all of this, there's a socio-political reality that impacts both our personal factors, our work environment, and the learning and educational environment. And I have another slide about this a little bit later, but of course, what happened with the Floyd situation, with COVID, with the war in Ukraine, with all of the climate disasters that we've experienced, and all of those realities, and I should also say the divisiveness in our country, of course, those will also impact all of these issues, which are interrelated in the work environment. So burnout is especially noted in frontline specialties such as emergency medicine, general surgery, and internal medicine and neurology. But I don't really think it helps to talk about who's got it worse. Everybody's burnt out, and we all know it. I will say that the causes vary by specialty and work site, so the solutions and the ways to remedy the situation are going to vary that way. It's sort of like all politics are local. This is a slide from Lottie Derby's work in 2018, just looking at burnout status and the prevalence. Another person just circled these for examples, just to show you that on this schedule here, neurology had the worst and pathology the least burnout. But as you can see, everybody's right up there. So I don't think we don't need to have a contest to see who's got it worse.
Dr. Bernstein,
yes.
Sorry to interrupt.
Sure.
I think the slide hasn't moved. So.
Oh. Well, it's moved on my here. No? What are you seeing? Oh, the screen sharing is paused. Wait a minute. Let me see what's going on here.
I see lots of doubt.
I don't understand. I don't understand why it's Zoom share. Let's try this. Oh, okay. Sorry about that. I don't know why that happened. Okay, let's see what I can do here. Well, I did the. Oh no, I'm back here. I'm not up to this slide yet. Okay, this was the slide I was referring to. Okay, I don't know. It's this little thing up here. You can see it all now, though. I'm sorry that I don't know why this is showing up here. Anyway, this just shows that there's high burnout prevalence in general. No, I can't. Okay. Burnout has professional consequences. I'm trying to move this. It doesn't want to go away. I'm afraid to shut this. Let's see. I don't know why this won't. Okay, well, this is the problem with Zoom. Anyway, this can lead to broken relationships, substance abuse, decreased quality of care, suicide, depression, those things that I mentioned earlier. Now, this is a really important slide. I'm sorry that this thing is interfering with it. I want to really talk about the differences between depression and major depression and burnout. So burnout is a response to chronic occupational stress. It manifests primarily in the workplace, and it may include feelings of sadness and depletion. It usually responds to distraction, rest, exercise, companionship, and time away from work, and there's no evidence that antidepressants are effective. And a simple way to think about this is that if you're feeling sad, depleted, annoyed, irritable, all the things that you can see with major depression, but when you get out of the work environment, when you go on vacation, even if you go home for the weekend and you feel better, it's probably burnout as opposed to major depression. But major depression can look a lot like it, and major depression may or may not be triggered by a stressful life event in a vulnerable person. So, if things are pretty bad at work, it can trigger depression in someone who's vulnerable. It tends to be persistent and pervasive. It's often associated with morbid feelings of worthlessness, psychomotor changes in suicidal thoughts or actions, and it rarely responds in a sustained way to distraction, rest, exercise, companionship, or time away from work, and it responds to evidence-informed treatments. So we don't want to be treating burnout as if it were a mental disorder, and we don't want to be missing depression when it happens. Okay. These next few slides, sorry about this, are important, I think, for people who are not in psychiatry to understand, especially. Suicidal behavior does not come out of nowhere. It really doesn't. More than 90% of people who die by suicide have a psychiatric illness at the time of death, and for most of them it is a major depressive episode, but nearly 80% are untreated at the time of death. However, suicide is not simply a response to extreme stress. Most patients with psychiatric disorders, including mood disorders, never attempt suicide. And at-risk patients have an illness and a vulnerability or a diagnosis for suicidal behavior, just like they do for any other illness in medicine, right? Not everybody who's overweight develops diabetes. You may be thin and in shape and running well, and if you have a bad history of coronary artery disease, you're at much greater risk. Get my point, I think. What is characteristic of people who have this vulnerability? They tend to have more severe subjective depression or distress, which is mediated by the anterior cingulate and the dorsolateral prefrontal cortex. So it's just important to understand this. They have altered decision-making propensities. This shouldn't say choose to act on. It means they act on powerful feelings and have less top-down control, that prefrontal cortex control that I mentioned earlier. They have impaired problem solving and learning, and that's mediated by the amygdala and the hippocampus. And they have distorted social perceptions, which causes sensitivity to negative social interactions, criticism and bullying, and insensitivity to positive social cues, which then impairs help seeking. So there is this biology that's involved in people who are vulnerable. About 50% of this diathesis is heritable. Early childhood experiences and epigenetics affect that, again, just like they do with everything else in medicine. The biology of the stress response in the brain is the product of genetic and epigenetic effects, and it's abnormal in people who die by suicide. And we hope to understand more as we understand the complex interrelationship between genes and epigenesis. So this is an important slide, which I think people ought to pay attention to. Again, sorry about this. How do physician suicide, people who die by suicide who are physicians, compare with the general population? So what's important to understand is that how in different professions, different things may be true about people who die by suicide. So for physicians, there's no difference in psychiatric disorder rates from the general population, but double the rate of alcohol or substance dependence. Very interesting. Nearly 50% of physicians who died by suicide used guns. Only a quarter used overdose. Now, this is a common misconception that physicians die by suicide because they have access to lethal means, which they, to drugs, but actually it's guns that are much more significant. Job problems were 3 times more common in physicians. That may get back to relating to that compulsive triad that I mentioned at the beginning. Toxicology shows higher rates of antipsychotics and benzos, but no difference in antidepressants. So we don't do a very good job of diagnosing and treating ourselves, that's for sure. Sorry about this. Like the general population, physicians include a suicide vulnerable group who have this diathesis, and the occurrence of a psychiatric illness creates the risk for suicide. And the compulsive triad may contribute to collective guilt in all of us after someone we know has died by suicide. I wanted to bring this to your attention too. There's been a lot of talk in the ACGME about suicide and the learning environment, but the ACGME knows about the causes of death, and what's important to understand is that the rate of death is tiny, it's little, resident death rates here were lower than in age and gender matched controls, and the leading cause of death was neoplasia followed by suicide and accidents. For male, that was in women, for men the leading cause was suicide. So very few people die in residency. Suicide is the leading cause of death, but it's still lower than in age-matched controls. And I think again, suicide is horrible, especially in a young person. It's really distressing to all of us, people with such potential. And we know that the suicide rates have gone up in the country in general. But that's not the major issue for people in training. And in fact, many people who come into medicine come into it with a high degree of resilience. I do want to bring this to your attention that we developed a toolkit for residency and fellowships about what to do if there is a suicide. That's just a resource. It was really put together in conjunction with the American Foundation for Suicide Prevention, which is a wonderful resource. I just want to call that out for all of you. So why are physicians so slow to seek psychiatric help? Well, there's the macho tradition and the stigma. The fear of loss of medical licensure or appointment. Now, what I want to say is that the AFS, the American Federation of State Medical Boards, has really done a great job of trying to reduce stigma in this area. They've published, the states themselves determine the questions on the licensing exams, and the FSMB has basically said, this is a template, don't ask stigmatizing questions. And a number of states that did before have now stopped asking those questions. And I hope that this is going to be followed by changes in credentialing applications at our hospitals. To be candid, and I'm a little bit embarrassed to admit this, I don't even know what's asked on at my hospital, and it may be something that you want to look at at North Alabama. And also, physicians are very isolated in a lot of their work. Sorry, that was. I'm going to move just a little bit to talk about the pandemic, but just briefly. This is a very famous slide that's been used by people working in disasters for a long time. I'm really showing this to you because it's showing a general trajectory. You can ignore the up to 1 year after anniversary because this has been, this isn't a discrete crisis the way other things are. It is much more like war, but there's pre-disaster, there's a heroic phase, a honeymoon phase, and I think we're really still in the disillusion phase. We may be starting to move towards reconstruction and a new beginning as the rates of COVID start to drop. But there's no question that the pandemic has fundamentally changed things for all of us. This is just data that you probably understand. It's been done in a bunch of areas looking at the mental health of frontline workers during COVID-19. And you can see how many, in different studies have, the majority have experienced distress. A small group have had PTSD symptoms, but not formal PTSD. A number have experienced depression and anxiety and insomnia. And you can see these are these are international as well as local. So what's happened really? Well, secondary traumatic stress, the presence of some PTSD symptoms caused by at least one exposure to traumatic material, and this is what happened in the beginning when so many people were dying. I think compassion fatigue is a big one, which is the inability to feel compassion for our patients because of our inability to feel compassion for ourselves, burnout, which we talked about, and chronic stress, which I think has affected all of us. And as I mentioned earlier, COVID wasn't the only stressor that we were experiencing. When this article came out in the New York Times about languishing, I was very dismissive of it. But in fact, I think a lot of us still feel fairly blah. So we had COVID, which led to languishing, which led to the George Floyd attacks, January 6th, the issues around vaccines, the shootings, the fires, all of it, the war in Ukraine, you name it. And so there's been a lot else going on. Sorry, but I'm keep hitting. Signs of, I'm just going to show you this so you can understand the signs of burnout and traumatic stress, and they sort of go across. So many of us have felt sadness, depression, or apathy. We felt frustrated, we felt isolated and disconnected. This can then lead to excessive worry or fear about something bad happening, feeling like a failure, feeling tired, exhausted, or overwhelmed. And that can lead into full-blown PTSD, being easily startled or on guard, having a racing heart and nightmares. I don't think most people have developed PTSD from the pandemic, but these other two areas are much more common. Vivek Murthy, our Surgeon General, went on a listening tour, and he had some recommendations post-pandemic. COVID exacerbated existing system challenges in medicine, but the interventions developed during COVID represent an opportunity for the future. Clinician well-being, both physical and mental, must be prioritized by leadership. The solution should be at the systems level, not just ad hoc. And interventions that were successful during the pandemic should become permanent, particularly those reducing stigma around mental health. You may know about this. There was a book put out by the Action Collaborative on clinician well-being and resilience. It was called Taking Action Against Clinician Burnout. You can certainly download it from the National Academy of Medicine website. This was all before COVID, however, I do want to say that. And they worked very hard on developing a system model which talks about frontline care delivery, the healthcare organization, the external environment, There are work system factors, there are individual factors, and there are they lead to clinician burnout or professional well-being, and the consequences, of course, for our patients, ourselves, our organizations, and for society as a whole. No question about all of this. This is called the Stockholm paradox. I'm trying to get this off here, which is retain the faith that you will prevail in the end, regardless of the difficulties, and at the same time, confront the most brutal facts of your current reality, whatever that might be. So this is what we have to do. We have to maintain a certain level of hope. At the same time, we're realistic about a lot of the challenges that we face. So what can you do? Well, you need to engage in self-care. I mean, I know this puts the burden and the onus back on you, but you need to think about what you feel. Are you feeling great? Are you feeling okay? Are you struggling? You need to check your battery, and you can look at physical sensations. Have you felt physical signs of tension, anxiety, or stress? Have you noticed any changes to your appetite, sleep, or energy levels? And are you able to do with those things you usually do? And if things changed? So we want to look at, are we feeling okay, we're all charged up, or where we're feeling empty, drained, and you need to think about it. And when your battery is drained, you need to think about what's going to help it get filled up again. So we need to remind ourselves that in challenging times, our minds tend to evaluate, criticize, and judge. This is particularly true of doctors. It's my fault. This is never ending. If only I was stronger. Everybody else seems okay. What's wrong with me? I mean, look at social media and how that does it to us. I mean, look, nobody ever posts on Facebook saying how miserable they are, or on Instagram or anything else. But in response, we need to focus on what we can control. That's what I was saying before, that Stockdale paradox. Acknowledge pain, stay honest with when you're feeling bad, saying, I'm feeling anxious, I'm feeling despairing. Respond with kindness and self-compassion. Take it easy, be gentle with yourself, and acknowledge that self-compassion and sadness can go together. You're suffering, go easy on yourself. Very hard to do, but try to do. It's a little bit of cognitive behavioral support. We need to be flexible when we're challenged. We need to label and accept emotions. Are you feeling anxious, angry, despairing, sad? Ride the wave. It's like surfing. You ride the wave. No emotional state lasts forever. Acknowledge the feeling, recognize them as valid, and return your focus to other things. Ride the wave of uncertainty. This is like the worst. There will be periods of heightened uncertainty. Know and accept that uncertainty will continue. Check on yourself, assess your emotions, and increase your self-care as you need it. And focus on what you can control, even if it's like cleaning your apartment or your house. I mean, something simple, washing the dishes. I don't even know, but to give yourself a feeling of accomplishment. You need to live your values too. You need to remind yourself of what anchored you to your job. I just met with fourth-year medical students yesterday in a transition to residency class, and they were given access to their initial applications to medical school and their personal statements, and they were asked to reflect on that. So one of the things I would say is, when you're challenged, think about why you got into this in the first place, how you're incorporating your core values and beliefs into being a clinician and into your professional identity and actions. Building positive experiences builds positive emotions. Changing what we do changes our mood, and it can increase your sense of connectedness to your colleagues, the people you love, your life, and yourself. Gratitude, I'm not so good at this one, but you need to cultivate gratitude. There's a lot of evidence that this is helpful. Simple and genuine expressions of gratitude towards each other can be very powerful. Expressing gratitude results in less stress, increased social connection, and a greater sense of efficacy. One word, what good thing has happened to you this week? Think of a statement of appreciation or gratitude. Celebrate a small win. I was trying to console a colleague, a friend actually, who hadn't gotten her first choice in the match, right? You know, for all of you can relate to that. And, you know, I said, but look at how far you've come. You know, this has been a 9-year journey and you finally managed to do it. I mean, we need to don't have it at my fingertips, but they're definitely there. So take good use of them. Make good use of them.
Thank you so much.
Thank you, Dr. Bernstein.
Anybody else?
Any more questions? Nobody has any other questions?
Yes, Dr. Bernstein. I have a question, like in your own experience dealing with residents, what type of, do you have any type of group activities in order to encourage, us talking about these issues? What's your experience?
You're all in internal medicine, right? Am I right?
Yes, all of them.
Yes.
Yeah, I'm going to make a suggestion. So in psychiatry, we for a long time there's been a tradition about having something called a process group, or you may have heard about them as a Valent group. And in psychiatry, it's often, it's part of the didactics, and it's like an hour a week where the residents come together as a group and they have an opportunity to share their experiences and things that are going on. And it's usually, there is a faculty member who facilitates that. Now, I can tell you, this is obviously going to depend. I know it's much harder in internal medicine, and you're probably not going to want to do it every week, but maybe once a month. And it may be that, there are psychiatrists around who would facilitate that, or psychologists. I just learned this past week even that one of the members of our CL service at the Moses campus at Montefiore has been running a group like this for the medical interns. It means every other week, and she does it for them when they're on their their clinic rotation, so it's not when they're on the wards, and they meet and they talk about things. It can be really, really helpful. I think it's a great idea. You don't have to make it mandatory, but you're going to get a lot of support from each other and have an opportunity to come together and just reflect on what it's like to be in training, which is hard, how to get through it, how to support each other. That's a very, very useful opportunity, I think. And if you can do that, if you could, maybe even once every 2 months, if once a month is too hard. But, I would strongly recommend that. It's very helpful. And that's in addition to, thank God it's Friday, going out for drinks or, playing softball or what, all of that's really, having picnics, all of that's really good too.
That's great. Yeah, maybe we can talk about implementing it.
So, Dr. Bernstein, just wanted to let you know that, we are starting the psychiatry residency program starting in July 1st.
That's right, I heard that.
Yeah, so we're starting that, and I think we are starting 2 batches at the same time, PGY1 and PGY2.
How many people did you, because there were a lot of people wanting to go into psychiatry that couldn't match, so.
So we are 5 PGY1 and 5 PGY2. And I think still we have a position for PGY2. If you know anybody, please let us know. And we'll be happy to look into their application.
Well, that's great. You should let the APA know that, the American Psychiatric Association. They used to keep a registry of unfilled spots, so you might want to let them know, or the training directors. I can help with that if you want to send me a notice. I can put it out on the training directors listserv, but it really needs to go to the medical schools, I think.
So I will let our program director to reach out to you, Dr. Narahari. And I hope in the next coming, when the batches come, I think we may request you to have one more session for psychiatry residents.
No, not a problem. Not a problem.
So, from our side, this is such a great, and it's an honor for us to have you here with all your experience and sharing your wisdom. So, we want, what's the thing that you want to, you have told everything in the slides. So one thing that residents should take, the most important thing from the as part of the 3 years of the residency training period. So what is the best thing that you want to take them, and what you think across the nation people are thinking?
Well, that's a really hard, because there are so many things, but I would say, let's see, well, I don't even, remember why you're doing this. Don't ever forget why you're doing this. You all came into medicine to take care of patients and help make them better. And that's sort of like the gold standard, and meaning and connection, really, really important. And of course, take care of yourselves and try to change the system for the better. I'm a big believer in trying to change things for the better.
Thank you, Dr. Glenstein. So another question I have, we talk about the residents most of the time, so about the faculty and also the staff. So this is another thing we need to also focus on. So what is your advice to the GME and institutions to take care of the faculty, the attendings, the program leadership?
I think one of the most important things to do is to understand that this is a shared problem, that well-being affects all of us, and that we need to get together to figure out what the solutions are. That means the faculty and the staff working together with the trainees. You don't want to be this way. We're not each other's enemies. We're in this together. Our job is to take care of patients, and we want to do it collectively, and at the same time, we want to be able to take care of ourselves and our own well-being. So I would encourage contact, communication, regular meetings and opportunities for the faculty and the residents to work together on solving these problems. I think that's very, very important.
Thank you so much, Dr. Bernstein. We really appreciate your time and giving us this valuable 1 hour of your time. We know that we have given to most of the residency programs in the country. We are honored and definitely, and we congratulate you on all the accolades that you have received and the impact that you have created in the medical fraternity. Thank you so much, and I want all our residents and faculty and the staff to give a big round of applause for Dr.
You're doing a really important work. You're taking care of the people of this country. That's really wonderful. And remember to take care of yourselves and why you did this. And you're in Northern Alabama. You're in a place where there isn't enough medical care. It's really to your credit, and I honor you for the amazing work that you're doing there. So thank you. Much more important than my talk. So
Thank you.
Thank you so much, Dr.
Thank you.
Thank you, everyone. Yeah, thank you. And in the best interest of your time, we got it. Thank you so much.
you're welcome. Bye-bye.
I train in infectious disease, but also did a subspecialty in transplant infectious disease. So those are compromised patients, solid organ transplant, bone marrow transplant patients, and a lot of times chemotherapy patients, which are also very immunocompromised. Today we're going to talk about some fungal infections. Fungal infection is a huge, huge, huge world. So we're going to talk about primarily 4 that you most likely will see at some point, if you haven't already seen at some point in your training during internal medicine. Okay. So the first one. Before we start, raise your hands if someone will start antifungals in a patient in the ICU critically ill on pressors, and they found a respiratory culture with yeast in the tracheal aspirate. Who will start antifungals on this patient? Just be honest.
How many days in are we talking?
We're talking about 2 weeks in the hospital admission. It's just a general scenario.
Yeah.
Okay? Who else?
I think if patient is spiking fever and all those, despite being on broad-spectrum
Okay.
I will start with
Okay. So 2. Who else? Typically, yeast in a respiratory culture doesn't mean anything.
No.
Okay? yeast in a respiratory culture is not equal to invasive fungal infection. And that's something you guys need to know because yes, a lot of times patients are critical ill, you get a culture, it's only, +2, +1 yeast. That doesn't mean anything, except your patient has risk factors. The key, give me 1 second. The key in all of this, in this talk, it's at the end of the day, you need to put your patient and balance what are the risk factors for this patient to have an invasive fungal infection.
Yeah, I was just going to ask, so because for a tracheal culture, I wouldn't. But let's say it's from like a bronchial lavage, would that mean anything if it grows?
If it's only yeast with no risk factors, no.
Okay.
It's just a colonizer. The colonizer, bacteria or yeast are just sitting there without causing trouble. It's always about the context in your patient.
So yeah, so is there no caveat for so if someone is failing to respond to therapy, is there any role for it then?
Yes, and that's exactly what we're going to talk about, yes.
Also, does it depend on what kind of yeast we're growing? I mean, if it's Candida albicans?
Yes, absolutely, absolutely.
But that
Because
does
yeast,
sometimes.
a lot of times, it just translates into Candida, right?
yeah.
But yeast can also be cryptococcal infections, which are important, yes. But yeah, I just want to lay out that topic. Just don't think because it's yeast equals invasive fungal infection. That's not it. It all depends on the risk factors of your patients. Okay, so let's talk about histo. So histo is one of the most common endemic mycosis, right? It's very common in central U.S., Ohio, the Mississippi Valley, the River Valley, and then the highest infections are in southern Illinois, Ohio, Kentucky, Mississippi, Tennessee. We're pretty close to Tennessee, and Arkansas. Exposures, your patients will have some type of exposure to bird, bat, guano, spelunking, cave exploration for people that do hiking, and cave exploration, bird roost, chicken coops, or prison, schoolyards. But at the end of the day, it's any exposure to soil, right? If your patients do gardening, yard work, hiking, and they are compatible with imaging and serology for histo, that's histo. And at the end of the day, it's the fungus are soil everywhere. We inhale it all the time, but our immune system, because we're fine, we don't produce the illness. But some patients will do. 50 to 90% will just have mild illness, subclinical symptoms in an otherwise healthy host, right? When you have acute pulmonary histo, you're going to have like an influenza-like type of illness. Around 14 days of incubation, you're going to have myalgias, you're going to have night sweats, you're going to have fatigue, malaise, cough, shortness of breath. You can have rheumatology symptoms. The most common one that I've seen in practice is erythema nodosum. Anyone know what is that? What is it?
Subcutaneous nodule.
Yes, they're painful, right? Good. Another common one is erythema multiforme. It's like a patchy, round rash. You can have pericarditis with this. And your severity of disease is going to be equally to how burden of histo you have in your body. The more histo in your body, the more severe disease you have. Chronic histo are symptoms for about 6 weeks or so, with progressive pulmonary infiltrates on lung imaging. It's more common in COPD patients, can resemble TB, pulmonary TB, or lung cancer. I have patients, they went for biopsies for presumptively lung cancer, and the pathology came back with histo, which is, best case scenario, but I can treat that pretty easily compared to lung cancer. And these patients will have, fever, night sweats, hemoptysis, weight loss, and changes in the upper lobes of the lungs predominantly. This is a chest X-ray on the left side with acute pulmonary histo, and you will see the arrow is pointing at lymph nodes, right? Histo, you will see a lot of lymph node compromise in your chest X-ray, in your CAT scans. So that's what you should focus on. And then the right one, it's a patient with pulmonary histo, which now develops cavitation. But the longer inflammation in your lungs, the higher chances to make cavitations in the lung tissue. Disseminated histo, it's a serious condition, right? It's the bloodstream infection of histo to any part of the body outside the lungs, right? See there, you can see histo in the brain, you can see a miliary type histo in the lungs, right? If you would see this patient in an Hispanic patient, you would think this is pulmonary TB, right? It looks identical as pulmonary TB. That's exactly what it looks like pulmonary TB, but this is all histo, disseminated histo. And you can even see skin lesions from histo. You biopsy that, and you will see histo. This is more common in very immunocompromised patients, right? HIV/AIDS patient with CD4 count less than 100, solid organ transplant patients, right? Liver, kidney, lungs, TNF-alpha antagonist patients, they use this infliximab, adalimumab for center, immunological processes also are high risk for this. It can be acute, it can be fulminant versus a subacute illness with a wasting illness. And then patients can die from this, can literally come in septic shock from this. So it's important to know. You can have fever, night sweats, respiratory symptoms, weight loss, lymphanomegaly, hepatomegaly, bone marrow infiltrations, adrenal insufficiency, GI involvement. Again, you can have all sorts of issues with this because it's disseminated. In your labs, you will see pancytopenia from bone marrow suppression and infiltration from this. You will have transaminitis, your LFTs will be elevated, you will have elevated your alphas, you will have miliary infiltrates like that CT scan that I just showed you. Some patients will develop HLH from this, which is another constellation of science and lab work, and also you need to do a bone marrow for that, for the diagnosis. Fibrosis mediastinitis, it's a chronic issue, but the problem is there is a robust inflammation process from the host in response to histo that can sometimes lead to necrotizing lymphadenitis, right? There's not good effective treatment for this. Antifungals and steroids don't work. Sometimes you might need to put stents if the airway is compromised or there's vessel obstruction from all of this. But this is just a absurd amount of inflammation in response to histo that affects vessels and airways.
How often does that happen?
It's very rare. I've never seen it myself. How we diagnose histo? The gold standard is pathology, or you need to isolate it from a tissue specimen. And the histo takes a long time to grow in the lab. It can take up to 2 weeks sometimes, right? The most available things for us, we can do serology. We can use urine antigen for histo. You can also do a antibody serology for histo. Those are sent to Mayo Clinic, typically come back in about 5 to 7 days. Bear in mind, a lot of times your serology for histo will cross-react with other fungal infections, typically blasto and cocci, okay? That doesn't mean your patient has histo, cocci, and blasto. It just means it's just picking up and cross-reacting with the histo test. We actually, I don't know if you guys are following, we have a patient here in UMC that has histo, but also his cocci is positive, but doesn't mean he has cocci. Regardless of that, the treatment for histo and cocci are the same, so we're going to treat for that. But just bear in mind, sometimes cross-reactivity for fungal studies can happen. A negative urine antigen, antigens in the urine that are negative, but his antibodies are positive, and all the pathology and the imaging is consistent with histo. And then you can use the antibodies also for monitoring. Treatment for histo, the definite indications for treatment is acute pulmonary histo, moderate to severe infections, chronic cavitary pulmonary infections, and disseminated or CNS infections, right? And this is a cool table. Basically, the treatment in a lot of these conditions is itraconazole. That's the gold standard. That's the first line treatment for histo. Then you can use posaconazole, you can use isobuconazole, but it's being more studied with itraconazole. Itraconazole, you load the patient with 200 milligrams 3 times a day for 3 days, and then for maintenance, 200 twice a day. The problem with itraconazole is it needs to reach levels. After 10 days, you need to get a level in the blood, and it has to be within certain therapeutic levels. If you're not achieving the levels, you just continue, you just increase the dose and continue until you reach a level. So that's the only issue with those azoles like itraconazole. For disseminated disease though, the gold standard for treatment is amphotericin, liposomal amphotericin for disseminated disease. And that's a great drug to start with for a lot of fungal infections, not only histo. And we'll talk about it in a second.
So, Dr. Costa, just a question. I mean, nowadays many patients in the outpatient setting even are on biologics
Yes.
for a wide range of problems. If someone is asymptomatic but is found to have a single or isolated cavitary lesion on a biologic, clearly has a need to stay on the biologic, how do you approach that?
It's a great question. What would you do?
I mean, I think hopefully the gold answer, I think, is that they should have had this worked up before they started the biologic. But in case that didn't happen, or it's a new lesion that's occurred on there, I think you have to treat and see if you can come off.
You're absolutely right, and that's a great question, and that's what we do and we see in the clinic all the time. I always have patients on with RA on immunologic that they do a workup. Part of the workup it's fungal infections, and then I have a positive result, and then you need to match it with symptoms, and you need to match it with lesions in the lungs, right? I've done it 2 ways. If my patient is completely stable otherwise and is healthy and young, I can monitor. If I have a suspicion that this could be an issue down the line when they start the biologic, because once you start that, your immune system is going to go down, then histo is going to be living the best life, right? So I treat them. I treat them preventively before they start the biologic. Yes. Okay?
Dr. Pablo, I have another question. So what really tells you this is like diffuse or this is mild to moderate?
That depends on how compromised is the lungs and then how bad your symptoms are. If the images are not super bilateral or diffuse, that could be moderate. If your patients are having a lot of symptoms like weight loss, night sweats, all that, pairing with a very bad CAT scan, that's moderate to severe. Okay? All right, and last thing for histo, we talked about, you have to have a risk factor for histo. I've had, in my clinic, it's pretty fun. I have a couple, a couple that they call themselves the histo couple because they're 2 young patients in their 30s that love to hike. The first time the wife came in and she had positive histo, she had a positive CAT scan with multiple nodules, and they say, hey, by the way, I hike with my husband is also positive for histo. So these guys were completely healthy, but they have a significant exposure with their hobby, which is hiking, right? So again, histo, it's in the soil, it's everywhere. There's gonna be a point you're gonna inhale it so much. And we've talked about the more you inhale it or the burden of disease in your body is more, the higher risk for you to get sicker. So that's what happened in their case. So rule is, there has to be a risk factor, but also completely healthy people can also have histo.
Is there any prevention when they say, I want to keep on hiking?
You treat it and then you monitor them. You don't give prophylaxis for histo, no, because they're pretty tough drugs that you cannot take for a long time. Okay. Next one is Coxi. How do you guys know? You guys know another name for Coxi?
Sand.
Your You're warm. Valley fever, right? Valley fever, yes. So it's very common in Arizona, right? If your patients are coming from Arizona, that has to, gives you an idea of this could be cocci. It's really one of the most common causes of pneumonia in Arizona, cocci. Okay? New Mexico, Southern California, West Texas, Northern Mexico, you can see there the map in the bottom left. Outside endemic areas, the spores carried on fomites or covering surfaces of automobiles can produce also infection. And then it's interesting, my boss actually had a patient that she transported a cactus from Arizona into her yard here in Alabama, and she developed cocci. Just because that plant was full of cocci. Which is pretty interesting. That's why ID is so fascinating for me, so fun. You guys think I'm a nerd, but if you ask the right questions, you will have your diagnosis just by asking the question. Because she asked, do you do gardening? Have you had any recent troubles? And that's what she said, oh, I do gardening and just got a plant from Arizona. So there you go. The primary entry of cocci is the lungs, right? You inhale it. And I forgot to talk about what does dimorphic fungus means. Do you guys know that? Yes. What is it? Okay. So dimorphic fungus, yes, two forms, right? When they're in the environment, what are they?
Spores.
Spores or mold, right? When they're in the body,
Yeast. Buds.
yeast. Okay, when they're in the environment, they're mold. When they're in the yeast body temperature, they change and then they become yeast. Because that's why someone said, depending on the yeast, will treat. Yes, exactly. Okay. Clinical presentations for acute cocci: 1 to 3 weeks for incubation. 60% are subclinical. It can mimic CAP. That's what I'm saying. In Arizona, it's one of the most common causes of community-acquired pneumonia. Your patients will come with fever, fatigue, cough, pleurisy, shortness of breath, eosinophilia. Okay, and then that's why it's called valley fever as well. More severe symptoms with more inoculum. Again, the inoculum or the burden of disease equals how severe your patients will present. You can have, again, rheumatological symptoms with inodosum, multiforme, very common in women. And 5% will develop sequela with lung nodules, with a thin wall cavity who might need resection at some point. And then the CAT scan is showing, again, nodules, some ground glass in that chest x-ray. Those CT scans is just showing lymph nodes in the periaortic lymph node, the subcarinal lymph nodes. The histopathology is just showing a lot of inflammation around the granuloma, and that one on the bottom one, that arrow is pointing at the S-furrow. It's a little tiny cocciform that is pretty pathognomonic for the disease. Chronic cocci, you can have cavitary lesions like in this CAT scan. Very common in diabetics, immunocompromised people. People will come with cough, chest pain, shortness of breath, hemoptysis, night sweats, fatigue, weight loss, and the imaging will show you cavitation lesions, ironopathy around it. This is a form of cocci, like barrel shaped, like a little train. In disseminated cocci, you can have extrapulmonary dissemination of the disease, very rare. It's more common, causing meningitis, okay? And then also you can have skin lesions, bone, joint infection from this as well, up to also epidural abscesses sometimes. If meningitis, you can do an LP. It's going to show you lymphocytic pleocytosis. with low glucose and high protein, your CSF will show also eosinophils, which is pretty which is pretty unrare, right? Like you don't typically will see eosinophils in a CSF, so that has to keep you in mind that something else is going on, and the culture, of course, is usually negative. The diagnosis, pathology, body fluids, and tissue, showing that spiral that I was showing you in the arrow a few slides back. It's highly infectious, okay? So if you ever have a patient and you are legit concerned this is Coxsackie, you need to tell your lab because they need to have the appropriate precautions because otherwise they will get infected. You can also have serology and antibodies for diagnosis and also for monitoring disease. Treatment is not indicated in normal hosts if otherwise there's not a complicated infection. Definite indications for treatment: high-risk patients, immunocompromised patients, disseminated disease treatment. Again, fluconazole or itraconazole are the gold standard for the first line for Coxsackie. And again, for AMPHO, it's for disseminated disease, severe infections, and also in pregnant women that you cannot use fluconazole. And then for CNS disease, you need high-dose fluconazole, and it's a lifelong therapy because it's really hard to eradicate. Okay. Aspergillus, we're going to talk about Aspergillus and Mucor. I want you to always remember Aspergillus and Mucor. They love vessels. They love angioinvasion. So your patients will have some type of angioinvasion type of symptom or finding on a CAT scan. Okay, and then we'll talk about that in a second. It's a very common invasive pulmonary infection. Risk factors: severe and prolonged neutropenia, HSCT, it's hematological stem cell transplants, GVHD. Anyone knows what's GVHD? Good. Graft-versus-host disease. Solid organ transplant, more than non-transplant. Again, TNF alpha antagonist that we already talked about. Chronic steroids, AIDS, and chronic granulomatous disease. Again, this is very important. You also need to think about risk factors. Okay, patients like solid organ transplant patients or hematological transplant patients, they will have chronic and long-standing neutropenia, right? Neutrophils are key to treat fungal infections. T cells are also key to treat fungal infections. These patients will not have either. Hematological transplant patients have zero neutrophils for a long time, depending on how long it takes for the bone marrow to click and then produce cells. Solid organ transplant patients have drugs that decreases the B cell and the T cell immunity. So that's why this population are at risk of infections like this. Severe or long-standing steroid use also poses that risk. So you need to think about what is the risk factor for my patient for me to think about Aspergillus. Lung infections are the primary site of entry, but we'll see it can get disseminated and causing extra pulmonary disease, including CNS. Another symptoms from Aspergillus is something called chronic pulmonary aspergillosis or allergic bronchopulmonary aspergillosis. This is more common in COPD patients and asthma patients. That I'm not going to talk about, but it's worth mentioning. Once you inhale the chlamydia, it germinates into hyphae in the lungs. And again, vascular invasion. They love to do that. So it's going to cause thrombosis, it can cause tissue infarction, or it can even cause massive hemoptysis, and your patients can die from this if it compromises a good vessel in the lungs. They come with cough, shortness of breath, pleuritic chest pain, hemoptysis, pretty common. And we're talking about frank hemoptysis, not just these little streaks of blood that you can have with bronchitis. We're talking about a good amount of hemoptysis. You can also have pneumothorax and pleural effusions with this. Considering patients with high risk, persistent fevers, Despite being on broad spectrum antibiotics, someone initially said that, yes, I should consider absolutely, if your patient has been on therapy with antibiotics for days and days, there's no improvement, there is something you're missing. So it might be worthwhile looking them up or working them out for fungal infections, absolutely. And this is the upper left is showing you the compromise of the vessels, see the thrombosis in the angio invasion. You see in the slide there all the inflammation in the granulomatous process. And who knows what is this? What is the only fungus that you can recover in blood? And this might be a worse question. Mm-mm.
Candida?
Mm-mm. Mold. You know?
No, I just wanted to ask.
Rhizopus?
The only mucor, no.
Rhizopus?
No.
Only fungus you can recover in blood.
The only fungus you can recover in blood. You will have fungemia with a mold in your blood cultures.
No,
Fusarium. Have you ever thought Fusarium? This is the slide of Fusarium. This is banana shape or canoe shape. That's why they say it. This is the only mold that you will find in the blood cultures. None other mold will grow in your blood cultures. Very cool.
Excuse me, sir. Just before you. So for the high-risk patients that we talked about, like in the ICU, so if we are suspecting like they have persistent fevers despite broad antibiotic coverage, do we start to treat them empirically once we've taken, or we have to wait for?
I will work them up. No.
Okay.
You will definitely have to work them up because committing them for a fungal treatment is not easy joke, right? It involves amphotericin most of the times. It involves drugs that can elevate your LFTs, can cause all sorts of problems, and you need to have, unless you have a strong suspicion that this is an infection, you should work them out first.
So our usual diflucan and stuff, that's just, because sometimes you just say start them on diflucan or
that's
okay.
just doing anything.
Okay.
So I think that's a follow-on kind of to Jen's question. Sometimes, particularly in the ICU, we have people on TPN, which we all recognise as a risk factor for fungemia.
Yes.
But we get into that point where we think our antibiotics may not be working, and then we talk about how best to screen for a fungal infection. I want to know what you think of fungal blood cultures. Is there a role for them?
You can do fungal blood cultures. The problem is they take a long time to come back. Unfortunately, in Nancy, we don't have a test that is really cool for fungemia. It's called T2 Candida. It's a PCR panel that detects in the blood all the major causes of Candida species. We're talking about Candida tropicalis, albicans, Crucia, glabrata, right? Those are the most common ones that will cause fungemia in ICU patients, absolutely, but unfortunately we don't have it here. So we rely on the blood cultures. Blood cultures nowadays are not the same as 20, 30 years ago. Before, those blood cultures were really bad to capturing or isolating fungal infections, but not anymore. Now the blood cultures are made in a way that they will capture it, but again, it's not readily available. That test, I was telling you, it's something that we can use right away. You'll have your answer in 2 hours.
Yeah. So here then, what do you recommend? We do fungal serology. Should we stop at that, or should
No. So are you talking about fungal infection, or are you talking about candidemia, which is two different things?
For fungal infection, we're screening for fungal infection.
We can do blood cultures, fungal blood cultures. We can do that, absolutely. If that picks up something, yes. But again, if your concern for fungal infection is really strong, then ID should be involved, and then we might need to do some further work. Yeah. But unfortunately, like I said, we don't have that test here, which is pretty cool, and we have it in other hospitals. So yeah, we talk about Fusarium. Fusarium is the only mold that will grow in your blood cultures. Okay. Diagnosis, you can have Aspergillus in respiratory cultures, BAL cultures, tissue samples. The pathology or the pathognomonic finding in a CT scan is called a halo sign. Anyone know what's a halo sign? Halo sign is what it is in the CAT scan in the upper left. It is ground glass surrounding by a nodule, okay? And it means it's the invasion on the vessels. For Mucor, there's a reverse halo sign, and it's the opposite. It's ground glass around a consolidation. I'm sorry, ground glass in the middle, consolidation outside. You can also have serologies for Aspergillus. The most common ones is called Aspergillus galactomanum. And you can also test it in the BAL as well. Serum beta-glucan. Anyone knows what Fungitel is? Beta-glucan, right? It's a component of the cell wall. Which two fungus does not have beta-glucan? There's only two. Who? Yes. What else? Mucor. Mucor and Crypto are the only ones that do not have beta-glucan in their cell wall, so that's why there's no benefit in testing for this. Every other fungal infection that we're talking about this will have beta-glucan, so your Fungitel will be elevated, right? Have you guys ever seen a patient with pneumocystis, PJP, right? Those patients will have high Fungitel. That's one of the markers of, in the setting of this patient having HIV and high Fungitel. That's highly concerning for PJP or disseminated PJP.
What's the role of LDH in that?
LDH also, yes, absolutely. LDH can be elevated in PJP. Yes.
Just in PJP.
Yes. Imagine you will have a halo sign, which is ground glass surrounded by a nodule and reflects the hemorrhage from the angio invasion that I was telling you about. These are images of Aspergillus. All of this is Aspergillus, right? And you see skin lesions with some bruising because of the angio invasion. You see in the bottom left, this is Aspergillus in the rhinosinusitis. And this one, it's an Aspergillus abscess in the brain from this, right? Bear in mind, you will see patients with CLL. We see patients with CLL. CLL, a lot of times, they just monitor patients with CLL and their counts and everything, but there's gonna be a point that they will use biologics, okay? Those biologics for CLL are highly associated with fungal infections, okay? So if you ever have a patient with CLL on a biologic, Imbruvica, I think is the one that it's called, you will have to think about that this patient might have a fungal infection. I had a patient that had CLL, he had 3 fungals. He had pulmonary Aspergillus, he had PJP, and he had brain abscess from Aspergillus. All of it from the biological. So those are not, just candy drugs we give patients. They can have serious complications from this, including infections like this. Treatment, the first line treatment for Aspergillus is voriconazole. Isavuconazole, it's a newer drug, it's more expensive, has been proven to be non-inferior to it. The issue with voriconazole, again, is that we need to load the patient and then we need to get levels. There's a subpopulation of patients that are called voriconazole hypermetabolizers, meaning no matter how much voriconazole you give them, you will never achieve therapeutic levels in the blood. How you diagnose it? You have to send a very fancy test for a CYP2C19, which will be positive for these patients, and then you need to completely change your perspective and then put them on another drug, because again, no matter how much you give them, you're never going to achieve levels. And the other good advantages of isavuconazole, besides being very expensive, is that you don't have to monitor any drug. You don't have to monitor any level. It's just you give it, you load it for 3 days, and then you give it. Alternative of treatment for Aspergillus, AMPHO, again, posaconazole, especially the delayed release tablets. Ampho, voriconazole, and isavuconazole have all activity against mucor and not other Aspergillus molds, which is a good empiric treatment. So that will cover pretty much all the bad stuff of fungal infections wise in a patient that is critically ill. Combination therapy, you can propose to patients with prolonged neutropenia or who have an elevated galactomannan and the BAL. And then for this, you use an echinocandin, right? Aminofungin, mycofungin, caspofungin for combination therapy. Ampho also again for severe disease in pregnant women because we cannot use fluconazole. Mucor is part of the Zygomycetes mold family. Reasonable thing I would do. Yeah. But remember, for candida infections with fungemia, we're talking about fungemia, candida infections, right? TPN lines, intra-abdominal infections causing spilling into the blood from candida species from the gut. You need to have a source control, right? You need to have some type of source control. Source control in the ICU for lines is removing lines, right? Source control, if this is a GI type of picture infection, you need to call the surgeons. They need to fix something because maybe there's ischemic bowel, there's a leak, there's something. Candida infections in the blood come from somewhere, and then that somewhere is probably lines or GI tract. I've also had Candida empyemas in the setting of perforation from the esophagus causing fistulas into the lung. That's also a thing. But those are the three major sources for your candidemias.
Thank you. If you find yeast in urine and the patient is asymptomatic, do we need to treat it?
That's a great question. Yeast in the urine, like a respiratory culture, doesn't mean anything. You never should treat yeast in the urine. If the patient has a Foley, change the Foley. That's all your treatment. Thank you for that.
So sometimes like in bowel perf or in like when there's been spillage of peritoneal fluid in the cavity, even post-op, the surgeons are often asking us or they themselves are prescribing antifungals
Yes.
for a short course.
Yes.
Is there any evidence behind that?
There is no evidence, but I don't think it's unreasonable to do. You have to think about in those patients with fecal peritonitis, that's a nasty place, right? So I think it's reasonable in the acute setting to treat them broadly and then de-escalate as you go and how the patient is progressing. Yes, I think that's reasonable to do. It's not unreasonable to do, but always because you have to think about how bad the process was and then moving forward, there could have been some translocation.
So I have a question regarding, for example, as a hospital, you have 15-16 patients on your list, and surely you're admitting a patient for pneumonia who have underlying immunosuppression and is actively on an immunotherapy or a chemotherapy or something like that, and you're admitting that patient. So what's the role of Fungidel there, or starting the patient empirically on antifungals in those days?
For a patient that is admitted for what?
Community-acquired pneumonia, with simple pneumonia.
So you need to pair your findings of your physical exam, your history, with imaging, right? If you have immunocompromised patients, we're talking about chemotherapy, RA on immunomodulators or anything like that, or transplant patients, you need to have a CT chest. A chest X-ray is not do anything because these infections are going to show you peripheral lung nodules that will not be picked up by a normal chest X-ray.
Right.
So you need to put everything in the context of that and then say, okay, is this a risk factor patient or not? And then go from there.
Any rule of doing regular Fungidels on these patients?
No.
What about any comorbidities like diabetes and a young patient being staying in the picture? So do you consider that as a
Diabetes, the only risk factor for invasive by itself diabetes uncontrolled is mucor.
uncontrolled?
Yes.
And that too for mucor, not for any other
Correct.
factor? Okay. So we take them as a normal patients like who are not immunocompromised.
Right, but they're already immunocompromised by having diabetes itself,
what
right?
I was thinking.
Yeah. But for the fungal part, mucor is completely associated. Anything else? I hope you guys learned something. I really like fungal infections, so I hope you guys again, it's a huge world, and I hope, if you ever have any questions, we'll be happy to answer them, okay?
Maybe a non-technical or a stupid question.
There's no stupid question ever.
There's a show called The Last of Us.
I know.
Yes.
That's impossible. 47 hours. Controlling our brains.
I mean, that's another story, but I played the game and I've seen the show, and it's pretty, the concept is cool, but I don't think.
It's not possible.
No.
And there is a new Canada Oris on rice.
Candida auris, yes, good job. Candida auris is a major emerging candida infection that is resistant to a lot of stuff, okay? I have seen it where I train in Michigan. I haven't seen it here yet, hopefully, or thankfully. But yeah, it's an issue.
So this patient who has like TPN and then has maybe possible fungemia, do we just take the line out and reinsert it, or we wait until
That's great. So when you have documented fungemia or candidemia, meaning candida in the blood, right? You need to first remove the lines. Second, you need to stop any broad spectrum antibiotics we're giving that are not effectively indicated. Why? The more you have broad spectrum antibiotics, the more you're going to kill your normal flora, and the more candida will rise, right? Because they don't have an opponent in the GI tract, as opposed to when the normal flora is there as well. Okay? And 3, you need to give a lung holiday, right? As much as you can possibly give a lung holiday before you place another line.
Thank you.
Yes. No, that's the staff will do this. Yes.
Right, I don't know if you need to repeat the
Some strains, some other no, you need to do ample.
because it takes forever. I don't think so.
That's it. Thank you guys.
One question, do we need to repeat the blood culture for...
What's that?
Do we need to repeat the blood culture for fungemia?
Yes. So if you diagnose a fungemia with blood cultures, you need to document negativity of blood cultures before you place another line. If you document your fungemia by the test, I was telling you guys, the T2 Candida panel is just a PCR, so you don't need to repeat your T2. You just treat for 14 days. Okay. All right. Thank you guys. Hey, oh, by the way, if you text me in Tiger Connect, I don't have that.